Psychotic illnesses cause immense distress and substantially interferes with wellness and functioning. It also results in significant distress and burden for family carers supporting a loved one with psychosis. Family integrated care recognizes that psychotic illness affects the entire family unit and fortifies the entire family in psychosis recovery. In the next few minutes, you'll learn about the lived experience of psychosis, the impacts of family integrated care, and how it can be implemented. The experience of psychosis has been described as frightening and difficult to make sense of. Here is one quote from an individual with lived experience of psychosis. "There are things that happen to me that I have never found words for, some lost now, some which I still search desperately to explain, as if time is running out and what I see and feel will be lost to the depths of chaos forever." Way and colleagues estimated that those with psychosis lose about 73% of healthy life per year due to their illness. Research has shown that individuals with psychosis experience immense stigma in their social environments, such as negative labeling and marginalizing, both within the healthcare system and outside of it. A stigmatizing social environment erodes protective social networks through isolation and lack of communication, making recovery that much harder. Although individuals with psychosis frequently feel disconnected and isolated from others, their suffering is often shared by family carers. Psychosis impacts the entire family unit. Many families are overwhelmed by uncertainty and worry for their loved one with psychosis. They have hundreds of questions like, what is psychosis? Will my loved one get better? And how can I help? They may feel disconnected from healthcare professionals who have critical information about how to support their loved one. Here is another quote from lived experience, this time from a family member. "It was like being on Mars for us. It's so much bewilderment, so much confusion. And then you have healthcare professionals throwing around terms like schizoaffective disorder and psychosis and major depression disorder, and we're just like, lost." The extreme hardship experienced by families supporting a loved one affected by psychosis is well documented in the literature. Family members often experience a complex grief reaction with symptoms of post-traumatic stress, depression, and poorer physical health, which contribute to significant burden and lower life satisfaction. External factors such as stigma, financial strain, and family isolation further compound family burden. Moreover, the very nature of psychotic illness can interfere with the relational health and the natural maturation of family relationships over time. Family carers are an essential source of day-to-day support for young adults affected by psychosis. These carers support their loved ones by coaching activities of daily living, like organizing schedules, paying bills, preparing meals, and housekeeping. They facilitate treatment adherence by managing medications and monitoring symptoms. They discern situational safety, such as managing crises and arranging safe living conditions. They also help to coordinate care by getting their loved ones to appointments and advocating and navigating within the healthcare system. Beyond practical support, carers also provide intense and frequent emotional support to their loved ones. Quantifying the depth of support that families provide is difficult, but one economic analysis done in 2006 estimated that the indirect resource cost to caregivers of individuals with mental illness was estimated to be 3.9 billion Canadian dollars. This does not take into account other costs that families take on, including purchasing medications, covering housing costs, and paying off debt, damages, and other losses. Imagine the cost to the healthcare system and other government organizations if they were to provide care that is equivalent to all that families do. Despite this, carers regularly feel cut off from their loved one's psychiatric care. Family carers are an essential part of the recovery process, and investing healthcare professionals' time and resources on supporting carers in their roles is well worth it. So, how do we support recovery from psychotic illness through family integration? The triad of care is a recovery-oriented model where there is an active role for healthcare providers, service users, and carers to engage cooperatively in the recovery process. This model distinguishes 4 dimensions of recovery: recovery of health, recovery of personal identity, recovery of daily functioning, and recovery of community functioning. Family carers can be involved in each dimension, but are especially essential in the last three. Because they are a consistent presence in the day-to-day lives of their loved ones, they're uniquely positioned to support these dimensions of recovery in a way that healthcare professionals are not. The triad of care highlights the need for equal power and open dialogue between healthcare professionals, service users, and carers. Fluid care continuity between inpatient, outpatient, and family organizations provides an underlying structure that parallels the triad. The effectiveness of the triad of care model has been corroborated by research on service users' perspectives on family integrated care and stories of lived experience. There is so much empirical evidence that the triad of care works. A recent meta-analysis by Schillick and colleagues studied collaborative care, which included multiple healthcare professionals and family engagement for treating depression. They combined findings from 35 randomized controlled trials, which included data from 20,273 patients. Their findings indicated that collaborative care had a small but significant benefit over usual care, and this difference persisted across 24 months. Further analyses revealed that manualized psychotherapy and involvement of family and friends were the core components driving the benefits of collaborative care. Preliminary findings have suggested the importance of family-integrated care in psychosis treatment as well. One study by Galderisi and colleagues showed the coupling of psychotic symptoms and day-to-day functioning drives worsening wellness. From these findings, they recommended early integrated care that emphasizes family in supporting functional recovery through life skills training and a structured environment to uncouple distressing symptoms from functional recovery. As another example, Koparal et al. 2021 studied factors related to the revolving door phenomenon, which is a tendency for wellness to decline in community resulting in repeated readmissions to inpatient treatment. One of the significant predictors of the revolving door was lack of community follow-up. The revolving door phenomenon can be effectively addressed by strengthening the triad of care. Family carers can be a key support in helping their loved ones advocate and navigate community services to maintain their wellness and independence in community. As stated in the lived experience story of an individual with psychosis, no one can go through their continuing recovery alone. I have learned that lesson. Maintaining good relationships with my caregivers is a vital part of being a mentally healthy adult. Despite the promise of the triad of care model, the implementation of family integrated care guidelines is the exception, not the rule, for many families. So what is getting in the way of family integrated care in our health system? Some barriers are logistic in nature, such as finding times and locations for meetings, having clear and consistently implemented procedures for healthcare staff to follow, and the fact that healthcare professionals are often overtasked and short-staffed as it is. Healthcare workers also grapple with legal and ethical barriers, predominantly their duty to uphold patient confidentiality. While concerned families may desire information about their loved one and their loved one's care, service users may decline to have their family involved, particularly if family is perceived to have played a role in involuntary hospitalization. The issue of confidentiality is complicated by illness symptoms of paranoia and anosognosia, a neurological symptom in which individuals are unable to recognize their illness. Paranoia and anosognosia break trust in both the family relationships and relationships with healthcare professionals, making the triad of care particularly difficult to implement. Barriers to family integrated care can also stem from family carers being overwhelmed by their role in caring for their loved one or uncertainty about what that role looks like. The knowledge and skills of being a family carer of someone with psychosis are specialized, and families rarely come into this situation with a clear understanding of what their role of caring could entail, or how and when they can be involved in their loved one's care. Finally, barriers exist on an organizational level. Healthcare professionals often lack the training to effectively implement family integrated care and may unintentionally isolate or stigmatize family carers. This comes from a general organizational culture that does not prioritize the implementation of guidelines for family integrated care. These barriers are immense, and yet family integrated care can start with you. There are many small things that healthcare professionals can begin implementing in their day-to-day practice. During hospitalization, there are two essential points of family engagement. First, engagement with family shortly after admission is an opportunity for family to provide important collateral information that informs diagnosis and treatment planning. It is also a time that information on the hospitalization process and community supports and resources can be offered to the family. Second, have family present at the discharge meeting so they can plan and problem solve how to support their loved one's functioning and independence in day-to-day life and facilitate care continuity. Distribution of an information sheet to families on psychosis, general hospital procedures, who they can contact at the hospital, where they can find resources, and the benefits of family integrated care can alleviate much of families' confusion and distress. Families and service users may need guidance and education on their role within the triad of care. The triad of care is unique to each family unit, and figuring out what that looks like may take some discussion and negotiation. Knowing when and to whom to release confidential information is challenging for healthcare professionals. If a service user is initially hesitant to provide consent to involve their family, it's important to check back as their symptoms and recovery goals shift, and especially as discharge approaches. Consent is a live contract, and the service user's preferences may change throughout treatment. Even if the service user chooses not to engage their family in their care, there are other resources that can help families prepare to support their loved one without breaking confidentiality or violating the agency of the service user. Even if you can't offer patient-specific information, offer compassion and resources. Support groups, psychoeducation and skills-based groups, and family peer support workers are great resources to comfort and empower families. Create opportunities for warm handoffs. This is a transfer of care between clinicians or members of the healthcare team with the patient and family present. This type of care coordination makes it easier for the triad of care to transfer from one setting or service to another. There are also things that can be done for broader implementation of family integrated care on a unit or hospital level. Standardize unit procedures on family engagement, while leaving plenty of room for flexibility. Give enough structure that staff know how and when to engage families, but can accommodate each family's strengths and limitations in supporting their loved one. Championing family integrated care on the unit can start with designating someone on the care team to help integrate families. Make it an explicit part of their role and a priority within their workload. Psychologists, social workers, and family peer support workers tend to be well positioned to support family integrated care. Because family peer support workers have first-hand experience supporting someone with a mental illness, they can provide a lot of valuable insight into the perspectives and needs of families, and creatively and compassionately develop solutions around family engagement. Finally, provide didactic and immersive staff training on family integrated care. Approaches that incorporate lived experience of both service users and their carers, as well as scenario-based learning, helps healthcare professionals practice the skills of navigating family integrated care. Check out these resources to learn more about lived experience and family integrated care. You can pause the video and use the QR codes, or find the full references of all the sources used in this video on the next 3 pages.